Just before I start, I'd like to make two apologies. The first one is I see lots of people out in the audience who are involved in the Safety and Practice program, so I apologise for the repetition you're probably about to experience. And the second one is I have my cell phone in my pocket and it is on. I have had the wonderful experience of starting to work in mid-central health area for the Central PHO, and have been co-opted into a wonderful program, partly clinically led by Paul here in the second table, which is the primary care palliative care program, palliative care partnership, and I just have a couple of people who are terminal, so you may pick up vibration. I've just kept it on silent, so I apologise if that happens. I'm going to talk about. Gotta get back here. I'm going to talk about the Safety and Practice program, which is really simple. It's a qualitative initiative based on safety in general practice, safety for our patients in general practice. And I chose this photograph here because clearly the individual's got safety in mind, but despite the gains and their safe approach, there's still some risks involved in what they're doing, which I think are really important to consider. So the content today, I'm going to talk about our journey, talk about the why of it, our structure, and I think the structure that I'm going to talk about is what we've chosen, but it doesn't necessarily mean it's a choice for everybody. So within that structure, I'll focus on more a reflection on my involvement, on what I see as important to make sure whichever structure you choose, if you choose a journey like this, are important to getting a reasonable outcome. I talk about the tools that we use. This is going to be a little bit like safety and practice on speed, so we might not have too much time to talk about those tools directly, and I think we might generate some discussion after Kyle's drilling down into one particular tool, which is the trigger tool, and then I'll talk about the outcomes that we have seen. So in terms of our journey, I think there's one word that really sort of describes how we were able to embark on that journey, and it's trust. It's wonderful having Anne here because I'm sure she knows this man, and how could you not trust that smile? So this is Neil Houston. He's Scottish. He is not a Scottish rebel. I hate to tell Anne, he actually voted to stick with England, so proud of it he is too. But Neil came to the Apex conference in 2013 and he spoke about the Scottish safety program, and really he wowed us with his story, but he really wowed us with, I think, what I would describe as clinical resonance. I think the people who were listening to him felt that it was implementable and that we would all feel confident in it because it just gelled. So we chose to call our program Haggis to Pavlova, and we say that we shamelessly stole from the Scottish experience, and that's what it was, because we developed that trust in the information that Neil presented to us. And I think in medicine we're not that good at that. We spend a lot of time fighting through data and losing sight of really what we're trying to do. But we were able to develop a really good rapport with Neil, and it was really important that we stayed in contact with that first year, and he's continuing to stay in contact with the second year. It just really continued that trust and allowed us to be confident in where we were going. I think, as we all know, you need to focus on the why. And I'm sure all of you in this room know the why of this sort of process, but if you don't focus on it enough at the start, I don't think you get the really important things which allow your program to work. And this is stuff that you should be doing before you're thinking about it. So what's important in your area? What's important in your PHO? What's important in your practice? And I think, these are long discussions, and I think the structural part of your journey also needs to go before anything happens. And as well as that, some of the data collection needs to happen, because one of the criticisms of our program by the first evaluation was that we hadn't collected enough data before we started to change. And in terms of scientific principles, I think that's obviously very important as well. So do think about the why, not just the why for the patient safety. The first 4 points within this, just to remind us about those patient safety data, are from the Scottish program and from evidence that they gathered And then the last one is local data. So 1 in 20 deaths in hospital, 5 to 17 admissions. There's such a wide range of that because this comes from the various health areas that were looked at, but significant admissions linked to adverse events related to medication. 4% of hospital bed capacity related to adverse events in primary care. And then their review of that data showed that 70% of them were preventable. So, all of these are really important reasons, and we need to think about that in context of our own programs. I think there's not a GP here who can't think of a clinical situation for why we'd want to improve the safety of our practice. We can all think of a time when we actually did something we could have done better, or something we even did wrong, if we're honest about it. And if we start thinking about that, then it helps us have a degree of commitment to this process. And this last one is local data. This is from the global trigger tool data, and I'll go into a little bit more involvement in this in a second. So that's 22% of admissions to surgical wards to harm that occurred within the community. Now, some of that harm came from private hospitals, but it's very hard to tease that out. But when we reviewed this data, it looks like it's a minimal amount of that. Most of the harm has occurred directly from primary care practices or from care homes, which we in New Zealand consider to be part of our primary care practice. So 22% of surgical admissions within the county's Manukau area from primary care due to harm events. The bottom part is just talking about the severity of those harms. And so F+ harms, more severe harms, more likely to have longer stays, longer rehabilitation, and 64 of those were related to medication. So again, it's the commonest form of harm that we're experiencing. So talking about structure, I think the structure, whatever you do, that you decide to, if you're going to embark on this journey, you need to get it right from the start. And so our structure is a collaborative. And, I think medicine's got to go this way, as we all agree. So we had 23 practices within the Auckland area that stretched from in the north, Silverdale, in the south, Pukekohe, in the west, Westgate, and in the east out, Beachland. So we covered the entire metropolitan area of Auckland. Koawatia, most of you, or many of you may have heard of Koawatia. It's a Counties Manukau health-based program, which is educationally orientated, but with a strong emphasis on innovation. And the Koawatia aspect of this was really important in helping us in regard to sort of managing the program or the changes that we wanted to make as we adapted the program. We had 6 PHOs, so there's 7 in the Auckland area, and I'm very pleased to know that the 7th has joined for the second year, and all 3 of the Metro Auckland DHBs. And certainly we hope in the third year that we're also having Northland involved, and hopefully there may be other groups that be interested as well. So just by the way, I'm just talking about the first year. I've no longer involved in the program, having moved to live in. So when I reflected on the structure, I don't think it matters which structure you choose, but I think that my reflection is that there's got to be really important parts to it. And again, these are the things you've got to do before you step into the program, before you start actually trying to make some change. And the 4 things that I came, and it's interesting seeing that Anne had 18 in her program, I've got 4 in mine. So the first one's funding. Then you've got to get the funding right. We're very lucky for the DHB support and the PHO support. But the really important aspect for general practice, I think, is thinking about time as a funding issue. So it's making sure you're protecting that time, you're giving the people who are involved in this program time. And there is a significant cost to the practice to do this. And that's one of those risks that I was talking about in that first part of that first slide. You have to think carefully about the funding issues before you start it. Expertise. So I think that the important part, we're very lucky to have Koawatia. There are people who are able to help us in change, innovation, but there's the expertise we have within our practice. And one of the things I'll talk about is positive deviance. It's a minor point I'll make at the end, but I think that as we're sort of sharing it, we need to think about the positive deviance. Of course, I'm now living in the Wellington region, so I should be saying absolutely positively deviant people. So I'm just going to flick to a website now, which is what I'm talking about, sharing practice. When you bring it up on, initially it'll come up with this menu button on it, but when you expand it, it may come up in a slightly different shape. It might come up looking like this. Well, after that menu button, or if you come in this shape, you just go to campaigns, and then you go down to safety and practice, and then you can scroll down to the resources part here. Here's Neil's lovely face again, so you'll be easy to find it. Now, the sharing expertise comes to this. This is public information. It's on this website. All of the information that I'm about to talk to, so you don't have to write anything down, is on that area of the website. Ko Awatea and Counties Manukau Health, the leader there is Campbell Brebner. These guys would love you to contact them if you're interested in this program. They'll be interested in expanding it, I've got no doubt about that. Go back to the presentation. But just remember that sharing that expertise, it's there that easily. Champions. You must have people to champion this, because people will question you, people will get sick of it, people might have buy-in at the start, but they say, oh, well, how's it changing? The Scottish program has taken 4 or 5 years to evolve, to develop, to show the improvement that they've had. So you've got to have people who are willing to champion it. And again, this picture is really important, because it's not necessarily the champions that you think will be there. And the smaller chap represents some of the champions that developed during the time. Some of the nurses who have taken these programs and run with them, and they weren't initially part of the core team. Some of the practice managers who have gone out of their way to develop extra information to support the program. It's really important. And then you need commitment. And I think that comes from, firstly, having that discussion before you start, and then you just need someone who's willing to really drive it, to run with it, to share the data continually across the practice, to jolly the team along when something goes wrong, when you collect data and show that last month the medication reconciliation dropped by 50% and you can't understand it. To enjoy the data that you're collecting and try and work to improve it. Okay, so I'm now going to talk about the tools that we use. So the tools that we chose were the Keya Bundles, trigger tools, and the Practice Safety Climate Survey. I'm not going to go too much into the last one, and Kyle's going to talk about the trigger tools, so I'm not going to talk a huge amount about that. You'll notice we've got Audit of Keya Bundles. We spend a lot of time with the language around this, and I still think we got it wrong, and I think the Scottish program got it right. One of the things that happened is we dropped the Keya. While we were talking about things, we dropped the Keya out of it. So we started talking about bundles, and everyone started talking about bundles because we're great at abbreviating things. It's really important you keep talking about Keya Bundles, because it resonates with us in general practice, and it very much resonates with the nursing team. So Keya Bundle is a set of evidence-based interventions that, when used together, significantly improve outcomes. And so it's really, these things are relatively easy to develop. We're really lucky that the Scottish people put the work in to develop them, and we have taken the Scottish programs and we've tried to meld them into things that fit the New Zealand context. But at the end of this last year, we developed an opioid management bundle, which was a new program, and Neil was really pleased to be involved in that, and may engage with that within the Scottish program. So it's different ways of you can choose Keya Bundles, and it doesn't take a huge amount of effort once you start thinking about it to develop those type of bundles. But we've chosen warfarin, medication reconciliation, and results handling. And again, based on Neil's evidence, we chose these things because we wanted to get people to engage in the program. And if you choose simple things that people can see an improvement with, then they'll engage with the program. After Neil's talk, I was really keen to jump into the climate survey, but Neil luckily talked everyone else out of it, and after a year I agreed that he was totally correct. So you don't need to focus on these, like they're all up on that Koawatia website. But this is what a Keya bundle looks like. And these are the bundles that we've adapted after the year from feedback from the 23 practices. This one didn't change effectively at all. And they're just really simple steps that you can audit your notes from relatively easily. Medication reconciliation audit. This changed a moderate amount because the differences within practice software. What we found is that people just engaged with that software differently. It was hard to audit things that were in the Scottish bundle, so we dropped a few programs. But the way we got to that is we got to that over 3 learning sessions. We had 23 practices talking about, or in this case, this was 8 of the 23 practices who were doing this bundle. We had 8 practices talking about what they'd learned in their process and how we could change it to effectively make it work for us, to make it easier to use IT systems to audit this. Results handling audit. And this was changed the most and it's become relatively small. Great feedback from the practices. And we only had 2 practices doing this, but it was really about simple stuff. There was no point looking at whether or not it had been coming into the practice. We didn't have to order that because we knew it had it automatically from the IT system. We didn't need to worry about it being sent to the correct doctor. It was an automatic process within the IT system. We really wanted to know when the person actioned it, when they opened it, when they looked at it, how often, how long afterwards, and then did they make some appropriate actions related to those results handling. But these are relatively simple bundles of care that you can do very simple audits on in your system. I'm going to talk about the outcomes shortly. The trigger tool. The evaluation of the program found that the trigger tool was viewed by GPs as a really difficult thing to engage in that involved a lot of time. So I consider that a failure on my part because this is something I just think is a massively enjoyable tool to use and allows for a relatively quick engagement within the practice. So a trigger tool is a structured case review with predetermined clinical triggers. The really important thing about it is that probably the most important thing is it's quick and it's structured versus slow and open. That's probably the most important aspect of it, and hopefully we might talk about that in the question time. This is just our triggers. I don't think we need to dwell on those, except for the fact that we developed these triggers after the Scottish program told us about their triggers, and Kyle told us about the work he had done in their triggers, and we sat down as a clinical team and developed these triggers based on what we were trying to achieve. And I think that if you were wanting to do that within a different area, or if you wanted to, engage with the safety and practice program, that would be something that you could easily have input into and think further about. I think these could be open to review and adaptation over time. Climate survey was the final tool that we used. We had a long debate about that. I think Catherine was speaking to you before, Catherine Wallace. Catherine presented to us the Manchester Safety Climate Survey, and Neil presented to us the Scottish Safety Climate Survey. In the end, we decided to go with the Safety Climate Survey from Scotland. But again, I don't think it matters which tool. And I think the really important feedback that both tools gave us was that when people thought about the safety climate, they started thinking about it more critically. And the experience was that when people repeated it, the scores went down. We don't think when they repeated it that their performance went down. We think it went up. But what we think is that people became more critical about it, that we had people thinking about the safety of their practice, and that can only be a good thing. So I'll just give you a brief overview of what we look at. So there's 5 areas that we look at: communication and leadership. Again, all of this is on that Koawatia website. We had a little bit of difficulty with starting. The reason we had difficulty with starting is we didn't have a baseline. We used the Scottish baseline data. There was 50 practices that were used in Scotland, and they got together and they developed a baseline. And we used that as a baseline just to give an initial comparison for the first guinea pigs doing climate surveys. But within a very short period of time, we will have enough to have our own baseline. So as people step into this into the future, we'll have a New Zealand baseline that we can compare ourselves with. And the baseline isn't important. It's not whether you score lower or higher against it. And that's really important when you're talking about climate surveys. The discussion is about what does it mean and what does it mean to you? And, you know, I think most of us have got safe practices, but we can get better and we can develop a better team around that. So that, you know, the scores aren't important, it's the discussion that it's important. And on that website there's a really important database, a really important document, which is how you develop how do you discuss the results in a team meeting, because that's the important thing. In this survey, it's still a practice-centred program. You get your results, you go back to your team meeting. And this is done with a survey monkey tool. So everyone in your practice gets a survey, they do it before a meeting, the results come back, a central group, which is Koawatia, collates the data for you, and you discuss the results in a very open practice, and the engagement is trying to make sure that everybody responds to it. The data is presented back in terms of clinical team and non-clinical team, managers versus non-managers, so owners versus non-owners, or partners versus non-partners. You know, so there's different ways that you can feed that data back. Okay. Just now, how's time? Couple more minutes. I'll quickly go on to some outcomes and benefits. So I think there's three ways that we need to think about it. We thought about collaborative outcomes, practice outcomes, patient outcomes. So collaborative outcomes are like this. You know, so this is the warfarin management, and I think we can be unbelievably proud of just seeing this type of improvement. And yes, the overall compliance graph on the bottom is still not sort of that high at the end of the year. We've only got 50% of everyone reaching all of the elements of the bundle of care. But that's a summation process. You can, every time you've got 5% or 10% less on the rest of your scores, then we're going to see that. But we'll see a steady improvement. And almost all of that came because we weren't documenting their education. So this graph goes to a wonderful difficulty in managing data. So in the first year of our program, what we did is not establishing that database before we started the program and not getting everyone really engaging with the data. What we looked like is we got some decrease in our quality. But what we actually got is different practices engaging with the data at different times. So in the first month, possibly, you know, someone had a massive improvement, and then in the next 2 months, another couple of practices came on with their data, and another 2 months they did more practices. So we're actually seeing dilutional effect of the original data, which is a shame, but it's really important to reflect on this and understand the data you're looking at. So the message of it is to collect the data first, then change, and make sure everyone's engaging with the data collection. The same process happened here. This is in results handling. So again, what we're looking at is just all of those bundles of care looked at separately, and the fifth slide, or the fifth graph, is then the whole bundles put together. One of the things I talked about before was positive deviance. And I think one of the difficulties with a program like this is that one of the challenges is we may lose sight of positive deviance. I'm really interested in what was practice one on day one of their data collection. I mean, did we lose sight of them when other practices came on that weren't so good? And would it have been nice to follow that practice? And do we need to go back and review that practice? What were they doing that was so good on day one to get such good, you know, engagement with some aspects of that bundle of care? So I think that's other aspects you need to think about in terms of your collaborative. Don't necessarily collate all the data. Be thinking about, okay, let's look at each individual data as well, because there may be someone's practice you want to think about. The team feedback here was just unbelievably positive. I could probably choose about 3 groups from this room and talk to you about the value that they had. This is just one group because they're particularly smiley. These guys did warfarin, and what we took was a group of nurses who were already as engaged in what they did is they took a group of nurses who were already as engaged in their warfarin management, and two of these women said that they had no confidence whatsoever in warfarin management. By the time they'd been in the program for 6 months, they said that they had 100% confidence in managing it. Their confidence in their ability was so good that they actually took that back to their practice governance group, and the governance group then mandated that the practice or the practices needed to use this system in the management of their warfarin. You know, the confidence that the ladies had in this program was just fantastic. And that occurred, you know, people here who are staring at me at the moment have done some amazing programs into form development within their IT systems that the whole practice we can engage with so that we've got a better, safer management of it. The Mangere family practice developed a form for the IT system, which is now incorporated into the IT program for one of the larger software companies for New Zealand. So the team confidence and engagement was just fabulous. Now, in terms of patient safety, we've only been doing it for a year, so I can't give you the proper feedback in regard to this. So shamelessly stealing from Scotland again, this is some of the data from just Scotland's improvement in terms of using a warfarin bundle of Keya and their improvement that they had. So I think the bottom figure, mean INR test per patient, with a clear significance and reduction in the amount of tests per patient per year. And to me, this is even more impressive. This is the time in the treatment range. And if you're on warfarin, what we know is the risk of you being on warfarin is nullified by the advantage if you're in the treatment range 60% of the time. All right? And so what we see here is such an improvement in terms of the time in the treatment range after the people within this Scottish Safety Program have been doing this for a few years. So I think there's outcomes for our patients, there's outcomes for our practices, and I think there's outcomes for us to develop collaboratives. One of our aims was to develop capability within the Auckland region to have quality improvement. And I think we'd have to say that we've got a positive tick for that, and the evaluation gave it. We've got a lot of work to do, but it's a step in the right direction. Thank you.